So I had a hard time using the link, but if you go to the VA WebEx site, it's veteransaffairs.webex.com.
Yeah.
And then just type in copy and paste the meeting number and the password from the invite. That should let you in.
Okay, great. Let me do that real quick.
Yeah, and then I'll, but if not, I think the slides I sent you over the weekend will be going through. So if we need to, we can just default to that.
Okay, so meeting information, that'll be?
You've got a meeting number, 199-678-1914. Yeah, that's it.
All right, I think we're in business here.
Okay, great. So since we have only a half an hour, we're going to try to be as efficient as possible. I'm going to encourage everyone to mute your phone if you're not asking a question, just so we don't have I don't know if that's me. Maybe I didn't mute. Okay. Yeah, so try to mute your phone if you're not asking a question to prevent feedback. I'm going to keep the chat window open. So if you do have questions, dump them in there, and we'll try to take them in line. If not, I might wait till the end. Hope is going to be helping us from an administrative standpoint. So if you're having questions with the audio or anything with the AV connection, feel free to chat with her directly. Hope McFarland is her name. She's going to be asking you to log your name so we can do a little bit of roll call as well. I'm hoping everyone can see my screen. So today, so thank you all for attending. This is our first of these brown bag webinars that we're going to be adding to the PHASER implementation. The goal of this call is to educate providers like yourselves about how to apply pharmacogenomics to your practice. We'll be holding these every month. They'll be just a half an hour long. As you know, you don't have to register or sign up. The only thing you need to do is bring your brown bag lunch, which I hope you've done. So today we're going to be talking about cases from cardiology. I am excited to introduce our speaker today, or our discussant. So Sunil Rao is a professor of medicine at Duke and chief of the cardiology section here at the Durham VA. He's an interventional cardiologist by training and practice, and world-renowned. And I could easily spend the whole half an hour going over his accolades, but we'll spare you all. So we've got 4 cases that we're going to discuss today. So we're going to go relatively quickly. You don't have to be a cardiologist to kind of understand some of the take-home points. I'm going to try to make things as generalizable as possible. And before we get started with the individual cases, we're going to be talking about clopidogrel or Plavix in all of the cases, and some of the pharmacogenetic interactions around Plavix. And so before diving into any of the cases, I think it's just really useful to level set and go over some of the basic principles around pharmacogenetics and clopidogrel or Plavix. So as you all know, clopidogrel is widely used in cardiology. We use it for a variety of indications, but the indication that we're going to be talking about today is around patients who are receiving coronary stents to either relieve stable angina or as part of their treatment for an acute coronary syndrome. And it's in that setting that clopidogrel has been shown to be very effective at preventing recurrent cardiovascular events. And so this includes really dangerous events like stent thrombosis, as well as other types of events like recurrent MI, stroke, cardiovascular death in the 6 months to a year following a coronary stenting procedure. Clopidogrel is a prodrug. That's what's packaged in the capsule that patients take. So that means it's inactive in the formulation that patients take. It needs to be bioactivated, so it needs to be activated by in the liver. So this is a blow up of a hepatocyte that I'm showing here on my slide. And so it has to go through a series of biochemical reactions to turn it from its inactive prodrug to this active metabolite. And that active metabolite, once it's produced, can then go out into the circulation and irreversibly inhibit platelets and prevent all of the cardiovascular events that we want it to do. This bioactivation process takes place by cytochrome P450 enzymes, and the one that's the most important that we're going to be talking about today is one called CYP2C19. Again, not totally important, but it's that's the one that we're going to be focused on. And so there are common versions of this gene where the enzyme that's produced doesn't work as well as the average person. And so since I've told you that this drug needs to be bioactivated, if you don't carry a version of CYP2C19 that works as well, you don't make as much of the active metabolite, you don't get as much platelet inhibition, you get less protection from cardiovascular events. So that's the basic pharmacology here. On the right is a flow diagram of the guidelines in terms of how to interpret this genetic testing for this variant. So if you carry on the right-hand side screen here, if you're something called an IM or a PM, so this stands for intermediate or poor metabolizer. That basically means you have one or two copies of a version of this gene that doesn't work as well. We would recommend one of the more potent agents, prazolam or ticagrelor, that are newer to the market. These drugs seem to be relatively immune to these genetic effects, but they come at the cost of being A, more expensive, and B, higher risk of bleeding. So with that basic foundation, let's dive into our first case here. So this is a case of JT. This is a 65-year-old male, diabetes, hemochromatosis. Came into our cardiology clinic here at the Durham VA with exertional chest pain. Was seen in the office. After history and physical, it was clear that this is likely cardiac in origin. A stress test was performed in the outpatient setting, showed ischemia in multiple areas and something called transient ischemic dilatation. So these are both of these are what I would call high-risk features of stress testing that we do in the outpatient setting. His ejection fraction was normal. We took him to the cardiac catheterization lab, and actually Sunil took him to the cardiac cath lab and showed that there was multivessel coronary artery disease, including the proximal segment of the left anterior descending artery. So lots of many coronary stenoses and in high risk locations. And so after reviewing the anatomy, the patient's characteristics, Sunil had decided that a strategy of multivessel coronary stenting was appropriate, and this was successful. The initial drug of choice was clopidogrel for this patient for a duration of 12 months. And it was around this time that Sunil had considered CYP2C19 testing for this patient. And so I thought we would just kind of go through some of these questions here. Sunil, if I'm gonna put you on the spot here a little bit. So, what are some of the features around this patient's case that maybe make you worried about clopidogrel in a patient like this?
Yeah, thanks, Deepak. I think it's important to talk about what the goals of therapy are. So in a patient like this, what is it that we're trying to achieve? And based on your presentation of this patient's characteristics, you're right. He's very, very high risk. And the question is, what is he high risk for? And he's at high risk for having a myocardial infarction. He's at high risk for having a heart attack. He's at high risk for dying from a heart attack. And then now that he's got multiple stents in his coronaries, he's also at risk for developing, stent thrombosis. So for people who may not be necessarily familiar with the cardiology parlance here, stent thrombosis is acute clotting of the stent, and it can lead to very, very large heart attacks. It is associated with a higher risk for death in the few hours after that event occurs. It is distinctly different from what we call in-stent restenosis, which is just development of scar tissue inside the stent that takes place over months. So it's a chronic process. stent thrombosis is a very acute process and it is very, very dependent on activated platelets that aggregate. So antiplatelet therapy is essential to reduce the risk of stent thrombosis. So in this particular patient, we want to make sure that we're maximizing his chances for a good outcome, and that means reducing his risk for potentially dying, reducing his risk for MI, and reducing his risk for stent thrombosis. I think the features that specifically made us think about testing in this case is the fact that he has multiple stents and he has very, very severe coronary disease that is likely much more diffuse than what we can actually even see on the angiogram. So in this case, we're thinking about, is there a more potent agent that we need to use? Because if he's not a responder or has hypo-response to clopidogrel, that is associated with an increased risk for cardiovascular death, MI, stent thrombosis. And so that was sort of the thinking that went in. Here, it's an efficacy question. It's not a safety one. We are worried about him having ischemic events more than a bleeding event.
Right. Yeah, so high-risk patient, one where you really want to, make sure that you're getting maybe the expected drug response because of, some of the consequences of the drug failing are pretty severe in a patient like this. Why not just put him on one of the more potent agents, and just forget about this genetic testing business?
Yeah, so that's a great question. And there are some practices and some physicians who will do that. Just a reminder to folks on the call, the more potent agents like prasugrel and ticagrelor have not been studied in the setting of what we call elective PCI. So this patient is not hospitalized with a heart attack. That's the setting in which these other agents, ticagrelor and prasugrel, have been studied. So it would be considered off-label. Having said that, the use of clopidogrel for stenting is also off-label, by the way. It has never been FDA approved for that indication. So, we use drugs all the time off-label, but in this particular case, because of our breadth of experience with clopidogrel, we tend to use clopidogrel as their initial agent. And then, our strategy has been to use genetic testing in specific cases. But no, there are certain practices and physicians who will just go ahead and use a more potent agent if it's a high-risk case.
Right, and of course it just comes with that higher risk of bleeding, right? And so because those agents are more potent, and if you can avoid them, that would probably be beneficial to the patient.
Yeah.
So this patient's genetic test results came back. He was a what we call a star 1. So that means we didn't find any abnormal genetic variants in this patient, and so he gets labeled as a normal metabolizer, or NM. And so we would predict that he would have kind of an average or the expected response to clopidogrel. And so coming back to our flow diagram over here, and for those of you that have seen a PHASER test report, you won't necessarily see a flow diagram, but you'll see under clopidogrel what the findings are and what the recommendations are. And so for him, the normal metabolizer status would recommend clopidogrel at a standard dose. And so for him, since he was already discharged on clopidogrel, there was no need to change therapy on him. And
Deepak, I think that I'm saying this correctly. In the randomized trial of prasugrel versus clopidogrel, when they looked at the people who were normal metabolizers of clopidogrel, their event rates were very similar to the prasugrel arm. So in this case, there's no additional benefit for using a more potent agent because he's a responder to clopidogrel, at least based on the data that we have. The outcome would be very similar. Is that right?
That's right. Yeah, right. That's a great point. Yeah, all the sub-studies and even some of the observational data have shown that people who are normal metabolizers don't get any additional benefit from a drug, at least in this setting, for a drug like from prasugrel or ticagrelor. But the take-home point here, I think, in this patient is high-risk patient where you really want to make sure that the drug that you're using is working properly, and so kind of working and thinking proactively and using pharmacogenetics in that scenario. I'm actually going to skip the next case, Sunil, if that's okay, and we're going to go to this case, case number 3. So this is a 96-year-old patient, known coronary disease. He'd actually been stented, 15, 20 years ago when he had a myocardial infarction. and did well at that time, was treated with clopidogrel at the time, comes back into us with a myocardial infarction. We've taken him to cardiac cath and show that he has a significant 3-vessel coronary disease, but only the right coronary artery is really amenable to any sort of stenting. He recovers after his, so he gets stented successfully, comes to our CCU, unfortunately had required a Foley catheter to be placed, and as a consequence developed some hematuria from that procedure. And around that, and because of his age and because of his hematuria, some of the more potent P2Y12 inhibitors were avoided. He was sent home on clopidogrel, and but again, because of some of the things that we've talked about, CYP2C19 genetic testing is requested. Before we get to the test results, Sunil, any features of this case that you thought might be or were salient in terms of thinking about how to manage him and his medications?
Yeah, so this is an interesting case. Similar to the previous patient, this patient had multivessel coronary disease. The big difference here, of course, is his age, and that's going to preclude coronary bypass surgery. In many patients who are at this age, they are really walking a fine line between recurrent ischemic events like a heart attack and obviously an increased risk of bleeding. One of the biggest predictors of bleeding with antiplatelet therapy, and we've shown this as well as other groups around the world, is age. And the older you are, the higher the likelihood you are at the higher likelihood you may be at risk for bleeding. That's because of frailty and sort of tissue integrity and those kinds of things. So in this case, this is really an issue of how to balance the efficacy to make sure that this patient who has unrevascularized coronary disease, right? So only the right coronary was stented. So it clearly has other disease that may, lead to plaque rupture and MI, and a patient who has already demonstrated that he is at risk for bleeding complications. So in this case, the results of the genetic testing will, I think, facilitate our decision-making around largely safety, I think. The concern with prescribing ticagrelor or prasugrel, prasugrel is an easy one. Over the age of 75 in their trial that led to FDA approval, there was no benefit in terms of ischemic events and a much higher risk of bleeding. And if you actually look through the FDA briefing documents, that risk was largely GI, but there was also a risk of intracranial hemorrhage and fatal bleeding in that older population. The labeling does allow you to lower the dose, the maintenance dose of prasugrel in patients over the age of 75, but in large part, we feel really uncomfortable with that, particularly because of that fatal bleeding risk. So prasugrel is out of the question. Similarly, ticagrelor, there are not a lot of data on ticagrelor in the elderly population. What we do know is that their large trial that led to FDA approval, if the patient had a stroke, then the risk of bleeding into that stroke in the brain was much higher if you were on ticagrelor versus clopidogrel. So we're sort of getting to a subset of a subset of a subset here. But again, given how potent that agent is, we feel a little bit uncomfortable in a patient who's 96 years old who's already demonstrated that they're going to be at risk for bleeding for treating with ticagrelor right off the bat.
Yeah, so it's kind of stuck between a rock and a hard place in many ways, given and trying to thread a needle between the ischemic and the bleeding of risk profiles of these medicines. So another place where genetic testing might be able to help you. So this patient, his genetic test results came back. There's a typo on the screen. He actually came back as being what's called a star2 genotype. So he actually carried 2 loss of function genetic variations in this key enzyme, and so he's labeled as a poor metabolizer. So these people have higher risks for stent thrombosis and other types of adverse cardiovascular events when treated with clopidogrel because they have less platelet inhibition, less protection from future events. And so you can see on the flow diagram here that we would consider prasugrel or ticagrelor in these poor metabolizers. As Sunil mentioned, these drugs are haven't been well studied, and they're more potent. And so they come with sorry. People don't mind just muting their phone. Thank you. And so this was a case that actually I was involved in, and we thought very hard about what to do with this patient. We called the patient, and it turned out, a week or two after his stenting and after the test results came back in, he was still having, significant ongoing hematuria from this Foley catheter, which he had to go home with. And after, thinking about all of the things that we've talked about, we decided actually just to leave him on clopidogrel, given everything and what might be best for the patient and optimizing their outcomes. It certainly gave me pause and gave us pause. Sunil, any thoughts or comments about this?
Yeah, what I love about this case is that it demonstrates how complicated this decision making is, and I think the common misconception about genetic testing based strategies is that it gives you a yes/no decision or a go/no-go decision, and the reality is we all wish life were that simple, but it really isn't. And in this case, I think it was handled so well because it is important to talk with patients about what the risks of the different strategies are, and to try and understand what their values are and what they are interested in getting out of their treatment. And when it comes to genetic testing for antiplatelet therapy, particularly in the patient population that undergoes coronary stenting, we need to think about this in sort of a multifactorial way. So there's the procedure, there's the patient, and then there's the platelet therapy. So if you want to think about it as the 3 Ps. So the procedure, we want to make sure that if we're putting in 1 stent, we're putting in 6 stents, we want to make sure that we're doing it in the way that reduces the risk for any kind of adverse event. And there are a variety of strategies that we use in the cath lab where we can actually put cameras inside the arteries and make sure we're using the right size stents and making sure that there's no complications, because we know that the occurrence of complications during a procedure also portends poor prognosis long term. So we want to optimize the procedure, and that's a big part of it. Many of the stent thromboses that we deal with as emergencies in the middle of the night are not because patients aren't responding to therapy or not because they're not taking it. It's because their original procedure was done poorly. So that's, factor number one. The second is, the patient, and that is where sort of the genetic testing comes in. It's where adherence comes in. And in this case, this patient clearly was still continuing to have bleeding complications. And so that discussion between the patient and their provider, I think, was the right one. And I think that they made the right decision saying, acutely right now, what we're worried about is making sure that this bleeding doesn't get worse. And then finally, that leads to sort of the third P, which is the platelet therapy. And in this case, despite the fact that the genetic test suggests that this patient may not be getting any response from clopidogrel, the reality is it's only a minority of the variables that go into this decision. And I would hope this patient continued to do well because, he got his procedure here at the VA. We sort of pride ourselves on doing a good job. I think he probably got a very good PCI. And so in this case, the decision-making was sort of more around the safety of this particular strategy rather than the efficacy, which we were hoping we would get with a really, really good procedure.
Yeah, and I did check into his chart as I was preparing these slides, and he did well. This case was actually from over a year ago, and has done well despite the concerns around his genetics. And so and I think to me it's the key take home point here is that genetics is just a piece of the puzzle, and we do this every day as clinicians. We integrate all of this information around patients and what drugs to prescribe, their comorbidities, concomitant medications, their preferences, the goals of therapy, and genetics is just one more piece of the puzzle. And so we don't want to go into it blindly. We want to we need to incorporate this additional information into that already complex decision-making process we're already doing every day. And so genetics in many ways is no different than what we're already doing. I tell patients, I think there is a concern that, because in PHASER we're sending results to patients that, gosh, a patient's going to see this result and see that they're on clopidogrel, and they're going to be worried that they're being put on the wrong drug. And first of all, I'll just say, again, since I was involved in this case, that didn't happen. I did talk to the patient about their genetic test results and how we think that after considering everything else going on with them, they should stay on clopidogrel. I often tell patients that, you know, your DNA hasn't changed since you were a baby, but you've changed tremendously since you were a baby. And it's all those other things that have gone on in that patient since they were born that also have to be taken into consideration. So a tough case.
Yeah. Well, I mean,
I think that,
we work with a few people around here, Deepak, that haven't changed since they were babies, but I'll keep those names to myself.
Yeah, I think I might have had even more hair at that time too, for those of you that can see me on the screen. Okay, so we've got one more case I'm going to power through since I think it is also another interesting one. So I'm biased though. So 77-year-old patient with known coronary disease has had prior stents. A lot of comorbidities here: prior stroke, chronic kidney disease, hypertension, diabetes, normal ejection fraction, comes in with a relatively moderate to large size myocardial infarction. This troponin was, you know, in the 80s, and that's very high. His cath showed that he had a single lesion in his right coronary artery, successfully treated with a stent. And because of all these high-risk features, was sent home on ticagrelor. But again, here are some concerns about the safe use of this medicine, and so genetic testing is offered. Sunil, any thoughts on this patient and how to manage them?
Yeah, so this is a great question because, you know, I'm sure some of you are probably thinking, well, this patient's 77, the previous patient was 96. You know, how much of a difference does that make with respect to potent antiplatelet therapy? At least based on what we know from the randomized trials, there was no increase in fatal bleeding with ticagrelor like there was with prasugrel compared with clopidogrel. Now, there are different trials, different patient populations. You have to be a little bit careful comparing across trials, but the data that we have suggests that there's really no increase in fatal bleeding with ticagrelor, and there didn't seem to be necessarily an interaction with age and the efficacy and safety of the drug. Having said that, again, we know that the older you are, the higher risk you are for bleeding complications. And so, yeah, I mean, is there a concern? Absolutely. I think there's always a concern with bleeding risk, and that concern may be a little bit higher in a patient like this who's 77.
Right. So in this patient, genetic testing came back. He was actually found to have a star 1, star 17 genotype. So the star 1 is what we call quote unquote normal. Star 17 refers to a version of the gene that actually might be hyperfunctional. So not a reduced functioning allele, but a hyperfunctioning allele. So he's classified as something called a rapid metabolizer. And so we think that patients like this are able to actually convert more clopidogrel to the active metabolite than average. They get a slightly greater platelet inhibition and slightly greater expected protection from clopidogrel. So, and there might be a little uncertainty around that, but certainly he's should be getting at least the average response to clopidogrel, if not a little bit more. And so here the decision was made to actually go in the opposite direction, to de-escalate. And the idea here is to move them from the more potent agent to clopidogrel, because we can predict that his response to clopidogrel will be normal, if not a little bit better than normal. And so using genetic testing here to be proactive about the safety of this drug and preventing a potential adverse drug reaction. Any comments here, Sunil, before we close out?
Yeah, I think this is another great case that shows how you can integrate genetic testing into decision making. The great thing about this case is that the strategy that was used here has actually been studied in a randomized trial. And Deepak, you and our group have been having a lot of conversations about this as a potential strategy to reduce the risk of outpatient bleeding in patients who are treated with antiplatelet therapy. This strategy of using genetic testing to de-escalate antiplatelet therapy was studied in a randomized trial called Popular Genetics. It's done in Europe, and seemed to be very effective. And so I think this is, another tool in our armamentarium to make sure that patients get the best balance between risk and benefit. And I think this case exemplifies exactly what we can do now.
Well, great. We've had a couple of comments come in through the chat window. I'm just going to try to tackle a few of them. Going back to our second case here, this the case of the poor metabolizer who we kept on clopidogrel. Just a good comment from Dan, one of our pharmacists, stating that this pathway here, CYP2C19 is just one gene in this pathway. There are other genes in this pathway there, so there is some redundancy in the system. And so even if you knock out one of them, it's not like you get no conversion to the active metabolite. And this patient may, for whatever reason, have more of those redundant pathways. So again, other factors, even there may be other factors beyond this gene that control drug response. And then in terms of getting the slides, we'll get those distributed, no problem. And then there was another question here about having acute stem thrombosis on Plavix. Would you then consider switching to prasugrel kind of empirically? And I think, if someone had stem thrombosis or drug failure on Plavix, and you can ensure that A, the patient was taking the drug, and B, that the original procedure was done appropriately, then that might be an indication to switch them. It's something, I don't know, it seems to vary by practice, but Sunil, any comments on that type of situation?
No, I agree with exactly what you said. I think that, if you can make sure that the patient was in fact adherent and there was no mechanical issue during the initial procedure that led to that stem thrombosis, then almost all of us would empirically switch to a more potent agent, provided the patient doesn't have any contraindications. Right. And by that, I mean specifically to prasugrel.
Right. The typical age and the prior stroke and the body size. So I think take-home points here today. We had three cases. The first one, we're using pharmacogenetics as a proactive strategy to try to, in these patients who we think would be really high risk for a bad outcome, and the alternative agents are either off-label or maybe you had some reservations about. That second case we discussed, the key importance of integrating the genetic test results with everything else we know about the patient, basically treating it as we treat any other variable that we use in drug response, and individualizing drug decisions to our patients like we do every day. And this third one is being, again, very proactive around using pharmacogenetics and preventing adverse drug reactions, namely bleeding, and trying to tailor the drug to the patient's genetic profile. A couple of key resources I wanted to make sure I plug. First of all, we have a nice one-page summary of all drug-gene interactions that you can find on the PHASER SharePoint drive. For those of you that are starting to kind of get your feet wet with pharmacogenetic testing and feel like you could use a little help interpreting test results and applying them to your patient, remember we've got interfacility consults at all of our PHASER sites. Each site looks a little different, and so, but it should be under the consults and it should be under PHASER. You should be able to find it. If you can't find it, send me a note, and I'd be happy to walk you through it. Meanwhile, so big thanks out to Sunil for lending us his time and his expertise. Our next brown bag seminar is August 10th, same time, 12 Eastern. I hope you guys find this useful. This is our first time doing it. We want to make sure it's of value and it continues. If you guys have a case, if you all have a case, any of you have a case, just reach out to me and we'll work with you on lining up a speaker, presenting the content, and getting it presented. We hope to continue these over time. So with that, I'm going to thank everyone for their time and their participation. Thanks, Sunil, and have a great afternoon.
Thanks, Deepak.